All right, it's a little past 11 Pacific time. Why don't we get started? I'd like to welcome you all to our fourth virtual Lupus Health Fair of 2023, presented by the Lupus Foundation of Northern California. My name's Tom Bakewell, and I'm the executive director of LFNC. It's an organization that is an honor to be working with, and I want to welcome you all back to this free Lupus Health Conference. You know, we've had two great sessions planned for today. We'd like to thank our sponsor, of course, our sponsors for the conference, AstraZeneca. We're planning another great conference that'll be held on September 30th. So mark your calendars now, as we'll have Dr. Alvin Wells, the director from Aurora Rheumatology and Immunotherapy Center, Franklin Wee discussing lupus nephritis, and then we'll have members of our Sacramento and San Francisco support groups sharing their lupus experience and answering any questions that you have. You can sign up for that conference today. More information is available at our website, lfnc.org/events. Also, I wouldn't be doing myself any favors if I didn't remind you to sign up for our 29th annual Outrun Lupus 5K on Saturday, September 23rd. 2023 at Campbell Park. Again, you can sign up now. This is a hybrid event as well, so you can join us from wherever you live in Northern California or beyond. So it's not too late to form a team and help us outrun lupus. So go to our website in the events section to find out more details. Thank you for joining us today and for your continued support of LFNC. So Sitara, I'll pass it to you.
Thank you for the welcome, Tom. Hello, everyone. I'm Sitara, and I will be your moderator today. I'm a lupus patient myself and have been honored to volunteer with LFNC for the last 7 years. We have a packed schedule today, so I will go over the agenda quickly and then we'll get started. The first session we have is a presentation from Dr. Rekah Mankad. Her presentation will be followed by our friend and fellow lupus warrior, Regan Burr. Regan will share her lupus journey and lead us through a brief exercise demo of Regan Moves. And now let me introduce Dr. Rekah Mankad. Dr. Mankad is an assistant professor of medicine in the Division of Cardiovascular Diseases and the director of the Women's Heart Clinic at Mayo Clinic in Rochester, Minnesota. Her primary focus is on the diagnosis and treatment of cardiovascular diseases in women. She initiated a cardiorheumatology clinic almost 10 years ago to address the high risk of CVD within the autoimmune inflammatory population. Dr. Mankad is also the co-director for education in the echocardiography laboratory. She's a fellow of the American College of Cardiology and a fellow of the American Society of Echocardiography. Dr. Mankad will discuss lupus and your heart. Welcome, Dr. Mankad.
Thank you very much. It's an absolute pleasure to be here. So you guys are all in California. I'm sitting in Minnesota, but we're having nice weather here as well. So hopefully everybody's enjoying their Saturday. So it gives me great pleasure to be here. And I encourage all of you, I'm going to be giving sort of a didactic presentation, but if you have questions through it, I think it's perfectly fine for you to send those questions through the chat, and I can be interrupted during the talk and happy to answer anything that you might have. So with that, I'm going to go ahead and get started. I'm going to share my screen here. I think that's going to work, I hope. Okay, I hope everybody can see that and we are good to go. I guess if anybody has an issue, you can let me know. Okay, so I am going to be talking about the heart in lupus, and we're going to just talk about various different conditions that can occur when you have systemic lupus erythematosus, and I'm just going to be going through some cardiac manifestations. Okay, I'm not going to be talking about any off-label usage, and I have no relevant financial relationships pertaining to this talk. So the overview for this is really, we're going to talk about the relationship between rheumatologic conditions and cardiovascular disease. And I say that first because I'm going to be mentioning other conditions, at least when we talk about some of the relationship. It's not uncommon for many patients to have various overlap rheumatologic conditions. So I'm just going to sort of give you some epidemiology. And then we're going to talk about what different cardiovascular conditions can occur in patients with lupus. And I'm going to be doing that with case examples of patients that I've encountered or run across through my clinical day. So when we talk about rheumatologic conditions that have cardiovascular risk, actually any of them have been linked to increased cardiovascular events. When we say cardiovascular events, that's a broad kind of topic or a broad range. We're talking about things like heart attacks. We're talking about heart failure. We could even be talking about things related to the heart valves and electrical system. But any of the ones that you hear mentioned about have been linked to increased risks. Most of the literature is actually on rheumatoid arthritis and lupus, interestingly. And there's been stuff in the literature for decades. And I always make the comment that rheumatologists knew about this a long time ago, but cardiologists didn't. And I am a cardiologist, and I sort of got somewhat accidentally exposed to some of this relationship when I actually was sent a lupus patient, and I wondered why I was seeing a lupus patient and started delving into the literature. But again, any of these conditions can be linked to cardiovascular events. And we look at that, I'm just going to show you some of the data on what we have seen over the years and why we know that there's increased risk. So this is specifically related to rheumatoid arthritis and the link to cardiovascular events and deaths. So here in the yellow bar are patients with rheumatoid arthritis, and those in the green are those without rheumatoid arthritis. And we see MI refers to myocardial infarction or heart attack. We see those with rheumatoid arthritis having a higher risk of heart attacks, stroke, death from any cardiovascular cause, and then any cardiovascular event. And you could see how much increase that is compared to a patient without rheumatoid arthritis. In lupus, we have data going back years. So this study is from 1995. And what it showed that early deaths were due to active lupus typically or infections. But when you looked at patients with lupus and what they were dying from later in life, it was really heart disease. And as all of you probably are aware, I'm kind of probably speaking to the choir, lupus has gone through so many advances over the years. There's great treatment for the active disease. So actually the deaths from the early disease have gone down dramatically because the lupus itself is better recognized and treated more aggressively. But unfortunately, heart disease is a later course and still needs to be looked at and addressed. There's multiple different cohorts out there across the country. In North America, there's a Toronto lupus cohort, a Pittsburgh cohort, Hopkins. So a lot of different places have looked at their lupus population, and they see that the prevalence of having a heart attack, angina is the symptom related to a blockage problem, or blockages of your other vascular tree, that's called peripheral vascular disease. All of those are increased in patients with lupus. But what is sort of really critical to understand is that this is happening to young patients. The mean event or the mean age when you'd have your first cardiovascular event was happening in very young women under the age of 50. And these are women that shouldn't be having heart disease. As was noted, I am the director of the Women's Heart Clinic, so I see women often. It's the primary focus of my practice. But what we know is that young women, premenopausal women, don't have a high risk of heart disease in general. But these are young women having cardiovascular events. So this is really important to recognize. In rheumatoid arthritis, there's been data out of Mayo Clinic and looking at our databases there, and we see that patients with rheumatoid arthritis, this is again early data, this was from looking at from 1955 to 1994, they saw that if you had lupus here in the orange, the light orange, you were dying at higher rates than what would be expected for your age and sex. When they looked at that closer, what they found was that why you would die if you had rheumatoid arthritis, no matter how many years you had rheumatoid arthritis, it was because of a cardiovascular cause. So the thing that was driving rheumatoid arthritis patients to die sooner than their non-RA cohorts or comparators was because of heart disease. So again, another bit of data that showed that this has been going on for a while. In a systemic sclerosis or scleroderma, we know that if your heart is involved, and this is pulmonary arterial hypertension here in the yellow, that's where the pressures are really high inside the lungs that then affects the heart muscle, the right side of the heart. If you develop that and you have systemic sclerosis / scleroderma, you would be dying much, much, much sooner than if you had no organ involvement or just had lung involvement, not causing these high pressures. So again, that condition in medicine, we've done a really good job treating that. So we're doing better with that pulmonary hypertension, but we see that the scleroderma patients also having heart attacks and strokes. And in red, we can see here that for even right away after your follow-up with having scleroderma, your risk of having these events is substantially higher compared to if you don't have scleroderma. And lastly, if we look at psoriasis, we see again another autoimmune condition that has inflammation. The worse your psoriasis is, and if you had psoriatic arthritis, we see here that you have an increased risk of cardiovascular death, heart attack, or stroke. So when we talk about this, the risk here is 1.5 times essentially compared to those who don't have psoriasis. So when we talk about the heart and how the heart can be affected with lupus, we see that any part of the heart can be affected. So this is the 4 things we're going to talk about. I had mentioned that I was going to talk about the electrical circuitry, but I'm not going to do that. I'm going to just do these 4. We'll talk about pericardial disease. That is diseases related to the lining around the heart. So the majority of us are born with a lining around the heart that sort of acts like a lubricant for the heart. So you can have pericardial diseases, which we'll talk about. You can have the valves of the heart be problematic, where the valves don't work normally. The heart muscle itself can be affected by rheumatologic conditions where the muscle is not acting properly. Either it's weak or the muscle gets stiff. And lastly, where we'll spend probably the majority of our time is ischemic heart disease, which actually refers to the abnormalities in the heart arteries themselves. And the heart arteries are those that supply blood flow to the heart. Remember, the heart is a muscle. It needs to have nutrients delivered to it itself, and that's done through the heart arteries. So we'll start with the pericardial diseases or the lining of the heart, and I'm going to show you a case. This is actually a 50-year-old man with lupus that I happened to meet, and I'll tell you when I met him, but he had actually presented to his rheumatologist feeling a little short of breath and had swelling for a few days. He'd had lupus nephritis and cutaneous lupus. He also has high blood pressure, and he had recently stopped smoking. He was on Cellcept and hydroxychloroquine as well as a blood pressure medicine. And when he came to see the rheumatologist, the reason he came was actually they wouldn't refill his Cellcept. They said, listen, it's been a while. You really need to come in and be seen. And that's when he said, yeah, I've been a little short of breath and not feeling well. And the rheumatologist noticed that the blood pressure was quite high and the patient's heart rate was high. They actually did a chest x-ray, and I won't show you that, but his heart looked huge on the chest x-ray. And that led to an ultrasound of the heart. And this is, again, I don't think anybody here is a physician on the call, so I don't expect you to know exactly what I'm showing, but I'll describe this. What this is here's the heart muscle. I hope you can see my arrow, but this is the heart muscle in the center of this black hole. The black hole that you see, or the black space that you see around the heart, is all fluid. That is a huge amount of fluid around the heart. That is not normal. That is not what you are supposed to see. So he developed this large amount of fluid that was essentially squishing his heart muscle. And this is actually called pericardial tamponade. So the heart was having trouble filling and ejecting blood because it was being squeezed by all this fluid in that space that's between the lining and the heart muscle. So I met him when we removed that fluid. So we got out 4 liters of fluid. So think of a liter Coke bottle. So we got 4 of those out of around his heart. We ended up putting him on high-dose steroids. Unfortunately, that fluid came back after we had fully drained it, and he ended up needing to have surgery related to that fluid coming back and being symptomatic. So what I want you to know is that pericardium is commonly involved in people who have autoimmune inflammatory conditions. And it's actually really common in lupus here. So if you look at lupus, about 50 to 60% of lupus patients at some point in their life are going to have some involvement of the pericardium. And usually that's a little bit of fluid. So this ultrasound that you're seeing here, this is the heart right in the middle, kind of sliced as a donut shape. We do this with ultrasound. And so we're looking at the heart in kind of a donut shape. And there's a little bit of fluid that we see right behind the heart. That is pretty common. It's not unusual. It's usually asymptomatic, but more often you can see this fluid when the lining of the that pericardium, that lining that we have around our heart gets inflamed. That inflammation that can happen to the lining is a very common occurrence in patients with lupus, because again, as all of you know, lupus is an inflammatory condition, and that inflammation can affect that lining not infrequently. And actually, it's the most common thing that we see is a little bit of fluid and the clinical story where you have inflammation of the lining. What's the clinical story? Chest pain. It can be chest pain that gets worse when you take a breath in, chest pain that feels worse when you lay flat or move certain ways. It feels better if you sit up or lean forward. And it typically occurs during a lupus flare most of the time. You can have just isolated fluid around the heart, but it can be completely asymptomatic, but a lot of times that fluid is related to when the inflammation occurs. We treat that inflammation. Again, a lot of lupus patients are already on steroids, but we can up those steroids. If they're not on steroids, we use other anti-inflammatory drugs like ibuprofen. Aspirin can be used, also a medication called colchicine, and that can all sort of decrease that inflammatory burden. Okay, next we're going to talk about valve disease. I actually also work in the valve clinic that we have at Mayo Clinic. So I see some patients when they end up having valve issues related to their rheumatologic disease. And I'll talk a little bit about that. So this is an 18-year-old patient that presented with a stroke. So what I'm showing you here in these two images is an ultrasound of the heart again. This is actually a different ultrasound where we put a probe into your food pipe or your esophagus. The esophagus sits right behind the heart, and so we get really good close-up views of the heart. So what we're seeing in the left screen is, this is called the left atrium. It's one of the top chambers of the heart. This is the left ventricle on the bottom. This is the main pumping chamber. And this right here is the mitral valve that is between those two chambers. If we zoom up on the valve, that's when we see an abnormality, and I'll see if I can freeze this and show you. See this little thickness here at the tip? That is not supposed to be there. That is an abnormality on the valve. And I'll talk to you a little bit more about what we say about that, but that is not normal. And in 18-year-old, first of all, an 18-year, we hope nobody ever has a stroke, but an 18-year-old certainly shouldn't be having a stroke. And this was the culprit. Now, it was only after finding this and doing this test that blood testing was done, and it was actually found that she had lupus and antiphospholipid antibody syndrome. These two things can occur together. And what we call this is, the terminology is called a Liebman-Sachs endocarditis. I know that's a big word. This Liebman and Sachs, they were two pathologists that first described this in lupus patients, where they had this abnormality that looked like an infection on the valve, but it's not an infection, and it's a mass that's related to blood clots and some other immune complexes that is very specific for people with autoimmune disease and more commonly seen in lupus patients. And I'm going to sort of dovetail that with another patient that I was involved in. This was a 29-year-old who had known lupus, and she had known antiphospholipid antibody syndrome. We call antiphospholipid antibody syndrome when you have these positive blood tests, but have also shown evidence of a blood clot somewhere. She had had one miscarriage that was felt to be related to this condition, as well as a blood clot to her lungs. That's called a pulmonary embolism. She had high blood pressure with all of her pregnancies, likely related to her lupus as well. She had been maintained on blood thinners, but she was having issues with chest pain, even though her heart arteries were normal, and she was having various headaches and visual changes. Well, when we looked at her valve, this is sort of a time course. Initially, this is her aortic valve. That's a valve between the main pumping chamber out to the aorta, which is like the tree trunk. Initially, her valve looked pretty normal. I'll tell you that because I do echocardiography, but that valve is normal. But in 2 years, the valve got thicker and it actually started to leak. And because of how much leak there was, she ended up needing to have heart surgery. She was also having evidence of mini strokes and strokes because of that thickening valve. And this is what her valve looked like. So this again is that special echocardiogram done with the probe in your esophagus. This was actually during her heart surgery. And this valve is highly thickened. You can see sort of a thin portion here up at the top. That's how the whole valve should look, especially in a 29-year-old. And you see this big thickening. And with that, there's this leak of blood blood going backwards. So she ends up getting heart surgery, and actually at the time of surgery, it got even worse where it was very thick. This is the valve in one view. This is the valve in the opposite view where we're sort of slicing it down kind of the barrel. And when we did the pathology on that valve, we saw this was the actual valve that was sent to the pathologist. It was sort of this white, bland stuff with some blood clots on it. And that is what we see in people with antiphospholipid antibodies plus lupus or lupus alone. This condition, I told you, it can be called Liebman-Sachs, but more specifically, it's called non-bacterial thrombotic endocarditis. Again, sorry for the big words. We say NBTE, and NBTE is where, again, there's blood clots forming because of the immune deposition that's happening that we see in lupus patients. So it's not an infection on the valve, although it can act like an infection, but it makes the valve not work normally. And again, I'm highlighting antiphospholipid antibody syndrome, but we can see it in lupus patients as well alone, but more often it's in lupus patients with antiphospholipid antibodies. And the valve, again, looks very white and pale, and you'll see immune complexes as well as clot on that valve. It's really important for me as a cardiologist or an echocardiographer to look for this and identify it, because these valves are harder to repair, and you have to figure out what type of valve to put in these patients, because when you have antiphospholipid antibody syndrome and you've had mini strokes, or you need to be on blood thinners, and the blood thinner the only blood thinner that's you're allowed to be on for this condition is actually warfarin or Coumadin, but sometimes it can affect the blood test that you typically check for warfarin, so it's an important consideration. But just in lupus itself, what kind of valve disease do we see? Well, you can see this wide spectrum where there's just these small little things on the valve. That 18-year-old that I showed you was relatively small, but this other patient that I showed you, it was a bit larger, bulkier. Most often it's the mitral valve. So this is a valve on the left side between the top chamber and the pumping chamber, but you could have it on any valve. The right-sided valves are less commonly involved. Usually the valves, because of this leaky stuff, they don't act narrowed, but they usually leak. So there's a leak to the valve that happens, but frequently there's no symptoms at all. However, depending on the size of those lesions and how mobile they are, and again, there's some blood clots on there, those things can actually leave the valve. And that's when you can have a stroke, a mini stroke or a stroke, like our 18-year-old patient that I described. And our 29-year-old patient also was having some mini strokes, which is why they decided to replace that valve. Again, the valve problems that you see in lupus patients are more common if you also have antiphospholipid antibodies. And we've actually done some studies at Mayo that show that people with antiphospholipid antibody syndrome probably should be having ultrasounds of their heart at some intervals to look to see if they have valve abnormalities. And this pathologic specimen by one of my colleagues in pathology shows that the abnormalities of the valve, where we see kind of in the cusps here, this kind of reddish, which is sort of the blood clots, to put it simply, in that valve. Now, I said that the pericardium, the lining, when you get fluid or inflammation of that typically happens with a flare of lupus. The valve disease is not as related to a flare. It can happen, but it might happen completely independently. The other issue that can happen is, if you think about it, if you have blood clots or things scab, right? Like this is damage, or can be damage to the valve, and it's sort of an abnormality. And if it doesn't present clinically, sometimes that valve scars down. So you can actually get a deformity of that valve after it's been scarred down, even though you never presented with the initial acute episode. And this is actually a patient I met, a 26-year-old that had come to see me in the valvular heart disease clinic because she had what's called mitral regurgitation, or a leakiness to her mitral valve. So here, remember I showed you that 18-year-old, she had that round nubbin. The 29-year-old had sort of that bulky stuff. This is the mitral valve here. So this is the left atrium. This is the main pumping chamber. And what we can see here is the valve's thick, but I don't see anything moving and nothing sort of flopping around. But this one part of the valve is kind of stuck. You can see this top part of the valve moves well, but the bottom part doesn't. And that's when you get this severe leakiness. So this is the mitral regurgitation. So blood is going backwards. Blood shouldn't go backwards to that degree. Most people have a smidge, that's normal, but this is a lot. And actually, when I saw her and saw this, I was worried that she might have had an episode of that non-bacterial endocarditis in the past. So she had known lupus, but we did more scanning and more testing, and we actually found that she did have antiphospholipid antibody syndrome and had silent strokes when we scanned her brain. So she ended up having to be on a blood thinner, and we replaced this valve with a mechanical valve because these valves typically can't be repaired, and this wasn't able to be repaired. And when we look at the valve disease, comparing rheumatoid arthritis and lupus and comparing it to people who have none of those conditions, which is in black, we see that rheumatoid arthritis and lupus patients have problems with their aortic valve and mitral valve far more often than people who have nothing, no autoimmune condition. They also have involvement of any of their vascular tree. So this is the carotid artery, the heart arteries, even the aorta, which is that main sort of pipe, and any portions of that aorta. So we can see that the vascular bed is involved often in patients with both rheumatoid arthritis as well as lupus. We'll move on to myocardial disease. So this is disease of the heart muscle. This is a 22-year-old female who comes in short of breath. She had lupus. She also had antiphospholipid antibodies. She'd been on blood thinners, was not on any immunosuppressives, but she felt bad. Her chest was achy. She had fevers. She had just traveled from overseas. She'd actually been studying. Her inflammatory markers were very high, and she was anemic. So her chest x-ray, what I'll tell you that it showed was there was all these fluffy infiltrates in her lungs. So they thought she might have an infection. When we did a CT scan, we saw some stuff in her lungs as well, but no blood clots were found. But the lining around her heart, this is that pericardium, looked a bit thick, and there was some fluid in that lining. And this is the ultrasound. Remember, I showed you it's common for lupus patients to have fluid if they have pericarditis. Well, she did have this fluid in the back of her heart. We see here, this is the heart, the main pumping chamber, and a little bit of fluid. So it was felt that she had pericarditis, but she was pretty sick. She got put on high dose steroids to help treat this, but she got worse. She decompensated. So here again is her heart. You don't see a lot of fluid here. Her pumping looks okay. It's not vigorous, but it's not abnormal. But then she really decompensated. She started coughing up blood, breathing fast, her heart rate was fast, and she was going into shock where basically her organs weren't getting blood flow. And then when we looked at her heart, the heart looked really, really weak, and she ended up having to go to heart surgery to help support her heart function. And this is what her heart looked like. This is the main pumping chamber. That's called the left ventricle. This is the right ventricle, and both of them are not squeezing normally at all. Here you can just sort of see it kind of jiggling a bit. And she had what we would say is myocarditis. I know a lot of people have heard that term related to COVID and maybe even COVID vaccine, but this is where there's diffuse inflammation of the heart muscle. We talked about it happening of the lining. Well, it can also happen of the heart muscle. It's actually pretty rare to have it, but it can happen with any of the autoimmune conditions, but lupus might be more common because it's so inflammatory of a problem. It's not predictable though. So just because you are highly inflamed doesn't mean you're going to get this. Again, this is pretty rare. We do see this in scleroderma patients where their heart muscle might get affected, but it's not from that inflammation or myocarditis, but it's actually from scar of the heart muscle. So they can get weak hearts from that. And rheumatoid arthritis patients and maybe the other conditions can also cause the heart muscle to be stiffer. We don't know exactly why that happens. We're looking at that further, but patients with these conditions, and maybe it's because they've had some inflammation of the heart muscle, that's not like we don't see that clinically, but if that's happened a few times, that may make the heart more stiff, and that can cause symptoms of being short of breath, swelling in the legs, and not having good functional capacity and not being able to exercise or do the things that you want to do. This is sort of a dovetail to that, a slightly different reason for the heart muscle to be affected. This is a 57-year-old who was short of breath and was having that leg swelling. She had kidney disease and high blood pressure. She had lupus as well as Raynaud's, and unfortunately, she was smoking as well. She'd actually been diagnosed with a condition where she had a genetic problem where her heart muscle was thick. So she came to Mayo just to get another opinion related to that. And she had this ultrasound, and you guys have all become experts since I've showed you echoes, but this is where the heart muscle is really thick. It's really, really, really thick. The function looks okay. It seems like it's squeezing okay, but the muscle is really thick. And we can see here at the very tip, there's something there. And when we gave a special, we call it an ultrasound enhancing agent, she actually had a blood clot inside her heart as well. That was unexpected. Well, even though she had this thing with the gene being positive for this thick heart muscle, one of my colleagues was just not okay with that. And they're like, wait a minute, could there be something more going on related to her lupus? And she happened to be on hydroxychloroquine. So we actually took a piece of muscle from her heart and we found out that she had something called hydroxychloroquine cardiotoxicity. Now, this is very rare, and those of you who might have lupus and maybe you're on this medication, don't freak out. This is very, very rare. But I point this out because sometimes it's not the disease, but sometimes the medicines need to be considered as possible culprits if you don't feel good. This is uncommon, but can cause problems where the heart gets stiff and thick. It can also cause various rhythm problems. And the only way to diagnose this is to take a piece of muscle out of the heart and you send it to the pathologist, and it shows some very specific changes. This particular patient, her hydroxychloroquine got stopped. Her heart got a little bit better, but unfortunately she felt terrible from her lupus. So there had to be a balancing act that had to come into play to take care of her. So she was pretty complex. Okay, lastly, we're going to spend the last amount of time talking about coronary artery disease or ischemic heart disease. Those are different terms you might hear. And this relates to the arteries. So this is the arteries that supply the heart muscle. This is where most of the literature came from as far as recognizing the link between lupus and heart disease. And so this is a woman that I met, but I'll kind of give you her background. 49-year-old who had actually come in originally and seen some colleagues of mine for chest pain. She'd had various episodes of chest pain, had been evaluated locally. She did have lupus, but in addition had mild connective tissue disease and also had mild Raynaud's. She'd had a stress test that they did locally. It looked fine, and ischemia means there was no evidence on that test that she had a blockage problem. So they kind of put her on a medicine and said, let's try this amlodipine, and which is a blood pressure medicine, which may help some spasm that you can have. It can help Raynaud's actually, can help spasm of the heart arteries potentially. So they put her on that. She kept feeling badly. She kept having some chest pain. So then they did a CAT scan of her heart arteries to see if there was any blockages. And what they found was no severe blockages, but she did have, this is a CT scan. Some of you may have heard of coronary calcium study, which looks at the heart arteries and looks at how much calcium is in the artery. Calcium in an artery is reflective of plaque that had been in the artery, so it's kind of a surrogate marker. And we see here a little kind of nubbins of calcium in her artery. So they said, hey, you probably should be on a cholesterol medication, and didn't do anything further. And then I met her now when she's 62 years old, and she is not doing well at all. She's having a lot of chest pain. She can't do what she wants to do. She'd been put on the statin, which is the cholesterol medicine, and somebody switched her amlodipine to a different medication. And her blood tests were really unremarkable. Her cholesterol numbers, these all looked pretty good. So I was like, you know what, something is going on with this poor woman. She is feeling badly. So we decided to do an angiogram where we looked at her heart arteries. And this is an angiogram. We go up through the wrist or the groin. We take a catheter to the heart, inject dye, and look for blockages. Now, she didn't have any blockages, and I kind of didn't expect her to. Her story and some of the other data, I didn't think she would have blockages. So this didn't surprise me, but I knew she wasn't feeling good. So I wanted to do more. And what we did is we gave a special medicine. And when we gave that medicine, this artery that you just saw that looked great spasmed. The whole artery sort of narrowed and spasmed from the mid portion all the way down, and you don't see it. When we did that, she had the pain that she had come in with, and she felt terrible. We gave a medication called nitroglycerin, which I'm sure a lot of you have heard about, and that opened the artery up beautifully. Now, why was this important? Well, it told me that her pain was coming from her heart. It told me what was causing her to have the heart pain, and it helped guide therapy really closely. So why do I bring this up? Well, because a lot of people, when we think about heart disease and people having heart attacks and people having symptoms, we're more likely to think about this on the left side of the screen, or plaque deposition atherosclerotic disease. So that's the classic, that's what we call the Hollywood heart attack, where people have blockages of the heart arteries, and that blockage may rupture and the heart artery sort of stops blood flow and you have a big heart attack. You can also have the same symptoms without the artery being fully occluded, where it's just narrowed. And this is classic, and this happens. But women tend to have more of these other two conditions, and people with autoimmune inflammatory conditions have these other two things. So spasm, that's vasospastic disease, which is what our patient had, where the artery was spasming at times. Now, tobacco will make that happen more often, but inflammation seems to make that happen more often. And she had Raynaud's, so she was prone to that as well. You can also have where you don't have tight blockages, but the artery doesn't relax well. So normally when we're supposed to exercise, our artery dilates, it gets larger to help maintain blood flow. But people who have this condition, the artery doesn't relax well. And again, we think inflammation, people with inflammation can have that problem where the artery doesn't relax well. So when we look at lupus patients, this was now 20 years ago, this study in a major medical journal, which looked at lupus patients and said, hey, let's compare lupus patients. Now, it wasn't a large study, but they looked at whether they had plaque in the carotid artery, which is the artery that goes up to your brain. And the lupus patients are in yellow here, and we can see no matter what age you are, so in your 30s up to your 70s, 80s, if you had lupus in yellow, you were more likely to have plaque in your artery going up to your brain. In that same journal, there was another group that actually looked at the heart arteries. So they looked at that calcium score that we talked about. Same thing, if you were a lupus patient here in yellow, you were more likely to have coronary calcium, which suggests that there was more plaque in those heart arteries as well. Now, this didn't look at whether you were having a heart attack or stroke, but just the presence of the plaque. So, and we know that that presence of plaque is a marker that you're more likely to have an event somewhere later in life. So patients with lupus had more of these. And why? Well, is it because they have lots of risk factors? A lot of you may know that when we go to our primary care doctor or cardiologist, they talk about these risk factors. These are called the traditional risk factors for heart disease. The things you can't switch are aging. So aging is a risk for heart disease, as well as your biologic sex. So men have more heart disease, certainly under the age of 55 or 60. After 60, when women are postmenopausal, they catch up very quickly to men as far as having heart disease. But these are the things that make you more prone to have heart disease. High blood pressure, which is hypertension, hyperlipidemia is high cholesterol, being a smoker, being diabetic, and not moving very much. So lupus patients have all of these, just like the general population. They have a bit more of a sedentary lifestyle, and that's because obviously you hurt. If you're in pain, it's hard to be active. And Regan's going to talk more about that when she talks about how well to move when you have when you're hurting. But this is really important that yes, these things all exist in a lupus patient. But when we see again, and when we look at those traditional risk factors, again, male being one of them, high blood pressure, diabetes, if you have these traditional risk factors, yes, you are more likely to have plaque. So yes, those all are important risk factors in lupus patients. But what we see is that even after you control for that, so this was a study of 300 lupus patients, they controlled for all of those traditional risk factors. So they matched you with somebody without lupus for the age and your biologic sex, and they controlled for the cholesterol numbers, high blood pressure, diabetes, and smoking. And so even if you look at all those traditional risk factors, and yes, they play a role, a lupus patient has a 10-time higher risk of having a heart attack or having dying from an artery blockage problem or having a stroke. So these two studies said that they didn't see that correlated with inflammation, that plaque that was seen. But if you were on good medications for your lupus with the use of steroids or chloroquine, you had less disease. But they did see, this is the really important thing, that those risk factors, high blood pressure, diabetes, high cholesterol, being sedentary, maybe being overweight, that those factors were undertreated in the lupus patient. Why might they be undertreated? Because the doctors focused on the lupus, right? And the pain related to the lupus and dealing with, the things that lupus sort of makes you come to doctors for. These other risk factors are sort of in the background and not being fully addressed or treated because you're sort of putting out those little fires of being in pain or uncomfortable and having infections or whatever else. So it's really important to look at these risk factors and look at them in a younger patient than you might do in a non-lupus patient. And why is it important to recognize that this happens? Well, because inflammation messes with your body. Having any reason for inflammation messes with the cholesterol, makes your blood more sticky, and actually makes you more prone to insulin resistance. All of that can make the arteries stiff. So yes, plaque can form, I showed you that, but it's also that the arteries don't relax well. So you can have symptoms even if you don't have plaque. And if you take inflammation, so SED rate is a marker of inflammation, and you take the number of risk factors, those things that I just talked about, high blood pressure, diabetes, high cholesterol, smoking, the more risk factors you have, we know the risk goes up of having plaque. But if you add more inflammation, the risk goes up even higher. This is looking at the carotid artery and how thick the wall is, and this is looking at the presence of plaque. Doesn't matter which of these two parameters you look at. The more risk factors plus the more inflammation drives you to have more problems with the arteries being stiffer, thicker, and having more plaque in them. And that's because inflammation doesn't just sit in the joints, right? Like if you have rheumatoid arthritis or lupus, yes, the joints hurt. That's where a lot of inflammation is sitting, especially in a rheumatoid arthritis patient. But the whole body sees that inflammation. That's why you can get a blood test to show that. So all the organs are seeing the effects of high inflammation. And so that is why in our current guidelines, so I as a cardiologist talk about risk assessment for patients all the time. And we look at high blood pressure, diabetes, and all that stuff. But we need to include inflammatory diseases. So our current guidelines that talk about preventing heart disease, these are the added things that we call risk enhancers. So when a doctor talks about your risk of a heart attack or stroke in the future, there's sort of a number that gets spit out, putting in your age and what your blood pressure is and what your cholesterol is. But these other things don't get part of that mathematical score, but we know it enhances the risk. So that's if you have family history, kidney disease, if you've had problems during pregnancy, if you've hit menopause early, but also these inflammatory conditions. This was added to the guidelines just a few years ago. Before that, people weren't really looking at this. And now we know that if you have these things as a provider, we need to know that your risk of heart disease is greater. Now, I don't say this stuff to scare everybody, but it's more to be informed. I think everybody should recognize that a patient with an inflammatory condition needs to be thought about as a higher risk patient so that we are very proactive looking at ways to decrease our risk throughout our lifetime. And lastly, a couple of slides about medications and their role in overall cardiovascular health. What about cholesterol medications? Well, if you look at cholesterol medications, they have, it's one of the #1 prescribed medications in the United States. In a lupus population, we haven't seen that it really changes whether coronary calcium progresses or statin medications are also considered somewhat anti-inflammatory. We haven't seen that it really changes the disease activity. But statins may help some of this relaxation thing, this what we call kind of vasodilatation, or the artery able to dilate. That seems to get better in patients with lupus. Now, I'm a big proponent of statin medications in the right patient. I don't give every one of my lupus patients statin medications, but I look at the pros and cons. We talk about the risk-benefit ratio. We look to see if there's already plaque and a lot of reasons. A younger patient who plans to get pregnant, I would not use a statin medication. But again, lots of different discussions here. And this is where heart healthy diet also plays a role, which I won't get into in this talk. What about steroids? Lots of lupus patients are on steroids, and they're on steroids long term. And steroids, they have a yin yang. I told you they help inflammation. They totally help inflammation, but long-term steroids can cause other problems. They can make the cholesterol go up. They can make you gain weight. They can make your insulin make you insulin resistant, or even worsen diabetes if you have it. So it's important to recognize, and the goal for steroid therapy is to, if you can get off it, or get to the lowest dose that'll hopefully control symptoms. And what we see is, and we won't talk about non-steroidals. I'm happy to answer questions if somebody has that. But if we look at steroids, the higher the steroid dose that you're on cumulative, the bigger chance it is to have that carotid artery thickness go up. But if you get put on statins here in the blue, that sort of mitigates the risk a little bit. So again, really important to talk about what the medications are, what they're doing to benefit the disease, but how they may increase heart risk, and then use other medications appropriately. So in summary, I hope I've shown you that autoimmune inflammatory conditions do carry a high risk of cardiovascular disease, and we specifically talked about lupus, but all of them do it. Any aspect of the heart structure and function can be affected by chronic inflammation. It's really important to look at cardiovascular risk in a patient with lupus or any other rheumatologic disease, but kind of is complicated. We don't have good guidelines on what we're supposed to do. We know that the risk is higher, but we don't know how much higher. We don't know what we should do to further assess that risk. When we talk about treatment and being prevented, I'm a preventative cardiologist sort of at my core. I think, I always say that, hey, if we really did a great job taking care of heart disease and you didn't need me anymore, I could find something else to do, although I don't have any other talents. But the treatment is really aimed at addressing all those traditional risk factors as aggressively as possible. And then I reach out to my rheumatology colleagues. We work in tandem and tell them, hey, we need to do something getting that inflammation under control. And I do have a high index of suspicion to look at the heart further in my lupus patients or any of my rheumatologic patients to say, hey, is there more going on with the heart than meets the eye? And with that, I really it's an honor to be here, and I thank you for your time and attention, and happy to answer any questions you might have.
Thank you so much, Dr. Rekah. That was wonderful. Are you able to hear me?
I can.
Okay, so I'm going to ask a couple questions that came up. So you mentioned about being proactive in decreasing the risk. Do you have any top suggestions for how patients can be proactive?
Yeah, that's a great question. So I think, lots of patients with lupus do go to their providers regularly, and typically it's their rheumatologist, which I think is great. But I think you need to make sure that you have somebody who advocates for the other things, right? So yes, I want your rheumatologist to deal with your lupus and your inflammation and look at your kidney function and your lung disease and all that stuff. But you need somebody, and I don't know if it's your rheumatologist, it kind of depends, but you need somebody to look at those other things. How's your blood pressure doing? I've had a lot of patients come to me and say, yeah, my blood pressure's high, but my doctor says it's just because I'm in pain all the time. Well, you got to look at that closer, right? Because if your blood pressure is running high all the time, whether if you're in pain or not, that's a risk for the heart disease, for having heart disease later. Your cholesterol numbers should get looked at. And we know that there's an interplay between inflammation and cholesterol numbers. And if you don't feel well, I think the key is don't always blame it on the lupus. As far as like, oh, if somebody's having chest pain, I've had patients say, yeah, my doctor said it's probably my RA or my lupus and it's my, my sternal bone. Now it might be, and that's pretty common, but I think you know your body better than any physician. So if something doesn't feel right, I think it's really important to have that looked at, but also to have somebody sort of look at the big picture and look at all the different things that are under that umbrella.
Yeah, absolutely. So you're recommending basically having another specialist that's looking at you.
Or your internist. I mean, it kind of depends on who's comfortable. Sometimes internal medicine docs are aware. We don't see this all the time. So I would say you don't necessarily have to see another specialist. You can also talk to your rheumatologist and say, hey, I've heard this. I understand there's higher risk. What do
Mhm.
you suggest? Maybe they might start some of the process. They might refer you back to your internal medicine doctor. So I don't think everybody has to run out and get a cardiologist, but I think you do want a primary care provider. That's a good preventative person. And I think all of us need it, whether you have lupus or not. There should be somebody sort of doing all those preventative things that we do. And as a female, I mean, everybody's really good about getting their mammograms every year and doing all of that stuff. And then when you turn 50, getting your colonoscopy, but people aren't as good about getting the blood pressure looked at or the cholesterol looked at and those kinds of things.
Yeah, and I agree there. And as a patient, I could definitely say that a lot of times any symptoms that come up is they think it's the lupus. The doctor will say, oh, it's your lupus. But yeah, getting a second look at that. Do you recommend any sort of like a baseline, like people just to go and maybe get some testing done?
Yeah, so, there's nothing, again, in the guidelines that tell you that you should have something done at a specific time. I would tell you the Europeans are probably a little bit more aggressive, but I think if you have lupus, depending on how active the disease is when you got diagnosed, I think getting baseline cholesterol numbers at some point in adulthood is important. Also, learning to know what your blood pressure does, if you're in pain, when you're not in pain. So but that's it. There is no guidelines to do an echocardiogram routinely or an electrocardiogram, which is an ECG routinely. I will say that I am pretty aggressive of getting an echocardiogram in my lupus patients, sort of as a baseline, but you're not going to find many people that do that because it's not really part of guidelines. Now, if you have scleroderma, there is guidelines that say scleroderma patients should get echocardiograms at baseline and then at regular intervals to look for that high pressure in the heart. So if you have lupus plus scleroderma, which some people have mixed things, then they get it. But for lupus alone, there is nothing that says you have to get certain testing at any specific time. But I think cholesterol numbers are not unreasonable sometime during adulthood, and also looking at them both when you're ideally you want those cholesterol numbers looked at when you're not in an active flare, because having an active flare at the time can actually sometimes make the cholesterol numbers look better than they actually are. So it's really good to get those cholesterol numbers looked at when you're in a period of not being actively in a flare.
Sure. And aside from the cholesterol and the high blood pressure, is there anything else that people should be aware of, maybe symptoms or signs to look out for?
Yeah, I think it's always important to be aware of your symptoms. And like I said, know what's your lupus and what isn't your lupus, which might take a while to figure out. But I think if you have symptoms of chest discomfort, chest pressure, chest tightness, especially if it's related to activity and it's progressing or changing, something's different, that's important. If you're short of breath doing activities that doesn't feel like it's just because you're deconditioned, you're like, wait a minute, I was walking a couple blocks and feeling fine, and now I'm winded after one block and have trouble and I have to stop and rest. If you have trouble with swelling of your legs that doesn't seem to be related to a long car ride or an airplane ride, it would be something important to recognize. Those are kind of the big ones. Obviously, anything that feels out of whack, I always say that your body, and it's always better to be cautious than not cautious. And sort of, if you have a symptom that's different and you get it evaluated, somebody might say, oh, it's not your heart, and great. But if you still continue to feel something that's out of the ordinary and somebody's not responding and looking further, I think finding a provider that sort of listens is really important.
Yeah, absolutely. And how about, are there any lifestyle methods to reduce our risk, like diet, exercise, those kind of things?
Yeah, you're going to hear more about that, but always lifestyle modification is critically important for anybody to decrease their cardiovascular risk. And again, in the lupus population, it's hard, right? Because if you're in pain, if you're having a flare, you're not going to want to go out and exercise. Or if you exercise, you may feel really uncomfortable if you've overdone it. So I think trying to figure out what activities you can do for how you feel and modifying those for how you feel is critically important. So, and what you do might be very different than your friend who has lupus does, right? So don't try to match yourself with somebody else. Do what you can. So the better we move, the more often we move, that's important. across the board for everybody, whether you have lupus or not, but particularly important in lupus patients because you are potentially more likely to be sedentary because of being uncomfortable. Along with that is diet, right? All of us should be eating healthier diets. And the diet that we say is heart healthy is a Mediterranean diet typically. So that's very little red meat, not processed foods, more of the olive oils, fish, nuts, tons of vegetables. But I will tell you that I've seen more often in my RA patients, but sugars actually can make inflammation worse. So I've had a bunch of patients with rheumatoid arthritis who say that they feel so much better when they've gotten rid of all of their sugars and that they sort of like really have limited, they don't have any processed sugars at all, and any sugars they might have are in fresh fruit only. Because we know that high glucose seems to aggravate inflammation even at a cellular level. So some patients may actually find a benefit if they are they get rid of some of their sugars.
Yeah, just cut that down. And another question that's coming through from one of the patients is, are there any other causes of myocardial stiffness, left ventricle, besides Plaquenil?
Yes, there's a lot. And so I would tell you Plaquenil, that's very, very rare. I showed it because so many patients with lupus are on Plaquenil, and we've had a couple of cases where Plaquenil has done this, but I don't want you all to go out running and say, oh my God, don't stop your Plaquenil, please don't do that. And it's very, very rare, but I just bring it up because it's just something that if people can't figure out what's going on and you're having issues with feeling short of breath, filling with fluid, and nobody can figure it out, that's just sort of in the back burner. But the more common reasons for the heart to be stiff and not work efficiently, high blood pressure can do it. So if you have high blood pressure that's undertreated, that can make the heart muscle thicker and stiffer. The other thing is having blockage problems. So if you, heaven forbid, have blockage problems in the heart arteries and the heart muscle isn't getting good blood flow, that can make the heart not relax well. And then inflammation of the heart muscle. So if you've had sort of what we call subclinical inflammation of that heart muscle, that may make it stiff over time. That's harder to diagnose. But if you have the symptoms that suggest that, a echocardiogram can be done. Sometimes other specialized tests can be done to see if you have that heart stiffness problem, and then to get on the right medicines to help improve that stiffness. But along with that, also making sure your lupus is under good control.
Thank you so much, Dr. Mankad. That was such an informative and great presentation by you. We really appreciate your time.
Thank
So,
you.
yeah. So now we're going to go ahead and move on and just have a break. Feel free, Dr. Mankad, if you'd like to stay on with us. And if you have to go, again, we thank you for your time and for your expertise today.
Thank you. And yes, I am going to break off, but it was an absolute pleasure. And yeah, and if anybody has questions and they didn't want to sort of say it in person, feel free to reach me afterwards. I'm happy to sort of give general opinions to any questions that people might have.
Wonderful.
Thank
you
you
so much. All right, so we'll go ahead and just take about a 5-minute break in case anyone needs to grab a water or use the restroom.